I'm going to talk a little bit about the basic principles of high-resolution manometry in evaluation of patients who have dysphagia. A little bit of basic, what is esophageal manometry? It is when we use a long catheter with pressure sensors throughout the catheter, pass it into the esophagus and stomach so that we can measure contractions of the esophageal body and the esophageal sphincters and see what happens during the swallow. The ones that we currently use is a high-resolution esophageal manometry, which is an advance from the previous version. Now we have 36 sensors throughout the whole catheter, about 1 centimeter apart. The advantage of this is that it can simultaneously record from all the segments of the esophagus, so you don't have to keep adjusting and doing pull-throughs. And you can more accurately localize the anatomical landmarks of the esophagus and the sphincter. So what protocol do we use? This is from the most recent Chicago classification version 4. Usually you want to measure swallows both in the supine and the upright position. You can start either supine or upright and turn to the other. Usually you do 10 supine swallows and then some what we call provocative measures that we'll talk about in a little bit with multiple rapid swallows. And then upright swallows with 5 upright swallows followed by a rapid drink challenge, which is another provocative measure. You can flip this around if you want to do it upright first. The other provocative measures that I just talked about, the multiple rapid swallow measure, basically you have patients take 5 rapid swallows, about 2 milliliters of fluid in rapid succession. You want to see how the esophagus reacts when they take this quick swallow. You will expect the esophagus to be, the esophageal function to be inhibited, but after the multiple rapid swallows, you will expect an augmentation, an increase in contraction of the esophagus. The rapid drink challenge is you have patients take about 200 milliliters of water through a straw in the upright position quickly. And what you want to see is what happens when they take these rapid swallow, whether sphincter opens, whether there are any signs of obstruction on the manometry. There are also other maneuvers as well that have been suggested but not part of the required protocol, like a solid meal test, a solid bolus swallows. A lot of these still have more emerging data supporting their use. So these are optional measures that you can use in selected patients. So how do we look at esophageal manometry? This might be a little bit of basic how we usually analyze the esophageal manometry tracing. We use metric from the Chicago classification. Just to orient you a little bit, the pressure down there is the base, where the basal lower esophageal sphincter pressure is. This pressure that changes when patient breathes is a diaphragmatic pressure. And at the top is the upper esophageal sphincter, and you can see the relaxation of the upper esophageal sphincter when the swallow happens. And when you look at this, you want to look for a parameter, something called contractile deceleration point, which is when the contraction, the swallow ends. So you can see that you can draw these lines on the contraction of the swallow, and that point where it changes, where it stops its progression is the contractile deceleration point. Why is it important? Because it can help us localize where do we want to measure specific parameters. The integrated relaxation pressure is measuring how well the lower esophageal sphincter relaxes during the swallow. The distal latency is to measure from the beginning of the swallow to the end of the swallow, which is where the contractile deceleration point is. Obviously, if patients have a spastic contraction, that distal latency will be very short. In normal swallow, you expect a normal longer distal latency. Another parameter is the peristaltic break. This corresponds to the transition zone of the esophageal body, which is where the skeletal muscle is transition to smooth muscle of the esophagus. Oftentimes you see a break there. Obviously a larger break could be abnormal. And then the last one is the distal contractile integral, which is a measurement of how strong the contraction is with each swallow. So basically, during the manometry, you look at each swallow and measure these parameters, each of these metrics. And then there are values, there are normative values that have been suggested where you can then score each swallow using these metrics. Whether they're using DCI, you can determine if they are normal, hypercontractile, or weak, or failed, a distal latency to see if they're premature or normal, a peristaltic break to see if they're fragmented or normal. The IRP will help you look for something like an EGJ outflow obstruction. And then you can also look at some other intrabolus pressures as well. So how do we apply these? When we score all of the swallows, then we can apply the Chicago classification. Usually the first thing you want to look at in this hierarchy is to look for whether or not the integrated relaxation pressure, the IRP, is normal or abnormal. If the IRP is abnormal, then you want to look to see if there's normal peristalsis throughout the esophageal body. If there's no normal esophageal body contractions plus an abnormal IRP, then it will qualify for one of the 3 types of achalasia. If the IRP is actually abnormal, but you have some normal peristaltic contraction of the esophageal body, in the previous version, we would just call these EGJ outflow obstruction in the last version of Chicago classification. But as I'll talk about in a little bit, it turns out that overdiagnosed a lot of people with EGJ outflow obstruction. So in the newest version, we actually would want a supportive measure. So we'll actually take those IRP at a different position. So if you took the supine IRP, then you want to look at the upright IRP. If the upright IRP is also abnormal, then they might have EGJ outflow obstruction. If there are supportive measures that might support it, like with an endoflip or with an abnormal time-bearing esophagram. And this is some example of an actual EGJ outflow obstruction versus another one where there's an elevated supine IRP due to some artifacts. So that's why it's important to have more than just the IRP in supporting it. If you don't qualify for any of this, if you do not have EGJ outflow obstruction, then the next step you want to look for is whether or not you have one of these other disorders of peristalsis. And this might include if you have all failed peristalsis, but with a normal IRP, you might have absent contractility. If you have a lot of premature swallows, so if you have a lot of swallows where the distal latency is short, and these patients might have distal esophageal spasm. If you have a lot of failed or weak swallow, a lot of ineffective swallows, that would qualify for ineffective esophageal motility. If you have a lot of swallows that has really high contractions, greater than 20% of them, that will qualify for hypercontractile esophagus. So this is the next step with this. If they don't have any signs of outflow obstruction, is to look for any signs of disordered peristalsis. And these are some examples of these disorders of peristalsis that you might find. What if it doesn't qualify for any of these diagnoses? That's when you have, we'll call it, there's no evidence of disorder or peristalsis. You might want to look for other reasons why the patients might have symptoms. So this is basically how we go through the whole Chicago 4 algorithm when we are doing the manometry. We talked a little bit, I know this is a little busy slide, but I'm just going to point out some of the provocative measures that I just mentioned. The first one is a multiple rapid swallow, which is what you see in the upper image. You have the patient take really quick swallows. You can see that during that very quick swallows, the lower esophageal sphincter relaxes, the IRP is normal. And then at the very end of the swallow, you will see that there's a contraction that's really strong. So if the DCI of the contraction is stronger than the average DCI of individual swallows, then you would say that a positive MRS response, which would correspond to a normal contractile reserve of the esophagus. It's a useful metric. It's been shown that it can help, especially in situations where you have someone that's undergoing evaluation for anti-reflux surgery. That's been data that have shown that if you have a normal contractile reserve, you're less likely to have dysphagia after anti-reflux surgery. The bottom part is the example of the rapid drain challenge. So you have patients take a lot of swallow of liquid, 200 cc of liquid really quickly, and you want to see if there's any signs of obstruction. On the left-hand side, it's a normal rapid drain challenge. You can see inhibition of any contractions during the rapid drain challenge. You see the lower esophageal sphincter relaxed. On the right-hand side is what you see in an abnormal rapid drain challenge. You can see the lower esophageal sphincter did not relax in this patient with an outflow obstruction. And you can also see this pressurization in the esophageal body, this pan-esophageal pressurization in the esophageal body. What happens is that when patients drink really quickly and the LES does not relax, all this water stays in the esophagus, and you see these pan-esophageal pressurization. And when you see this, this might suggest some type of outflow obstruction of the esophagus. Another one is something called postprandial meal challenge that we sometimes see, and this is mostly for patients that you suspect having rumination syndrome. So these are patients who eat and they start regurgitating and actually throw up and regurgitate the food that they eat right after eating. And you usually do that by doing the manometry, have them eat a meal, and watch them with the manometry. And what you would expect to see is that there will be a contraction in the stomach in patient with rumination. And on impedance, if you pair it up with an impedance, you'll see the food content coming right back up during the manometry. So that's one way to actually confirm and diagnose rumination syndrome. So what are some of the common indications? When do we do high-resolution manometry? We want to diagnose or rule out any esophageal motility disorders, but specifically what we call actionable disorders. These are the ones that if you treat them, you expect the patient may get better. What are some of these? Achalasia, some cases of outflow obstruction, maybe some patients with spasm or hypercontractile esophagus. Maybe if you identify patients with belching or rumination, if you treat the disorder, they may get better. So you want to identify these. Another one is if you're thinking about doing some sort of reflux monitoring, when you place a pH or pH impedance probe, you want to make sure that it's localized correctly. You want to do a manometry beforehand to see where the lower esophageal sphincter is to make sure the catheter is in the right place. Before an anti-reflux surgery, you really should do a manometry because you want to look for any contraindication to surgery. A portion of patients with things like achalasia or EGJ outflow obstruction may mostly present with reflux-type symptoms. So before you do an anti-reflux surgery, you want to make sure that you rule out those conditions before you send them for fundoplication. There are also some parameters, like we just talked about the multiple rapid swallow response, may also prognosticate outcome of these anti-reflux surgery. Having said this, what are some of the most optimal use of manometry in clinical management? Like, how would it most help you? And I think one of the things that I want to emphasize on is this idea of an obstruction, of obstructive physiology. Because most of the patients who come with transit symptoms, when they feel like things are not going through, it's because of these obstructive physiology. There's an obstruction going on. That if you were to treat the obstruction, the symptoms will get better. If you do things like doing a fundoplication to make the obstruction worse, then the symptoms will be worse. And there are a number of conditions where you can see here the way they cause symptoms like achalasia or EGJ outflow obstruction are due to an obstructive physiology that's found. So really, how the manometric pattern translates to symptom is really identifying these obstruction that might be causing these transit symptoms and see if you can actually treat that obstruction. Unfortunately, as we now know, there's really no single universal gold standard metric that can diagnose what is true obstruction. It really depends on the balance between how well your contraction is and how much of a pressure you have at the lower esophageal sphincter or the EGJ when you swallow. And one of the things is, we talk about this EGJ outflow obstruction diagnosis, which is when they have an abnormal IRP, but with normal contraction. It turns out that this is a very heterogeneous entity because there are a lot of things that might cause this EGJ outflow obstruction pattern on manometry. For example, there are anatomical reasons like a large hiatal hernia or diverticula that might be compressing that can cause these EGJ outflow obstruction. It could also be functional. There are primary issues that can cause it, or even secondary issues like medications, like opioids we know can cause outflow obstruction. So looking at this, then diagnosing true obstruction that you can treat and get better might become even more challenging. And one of the factors that we always focus on is this IRP, the integrated relaxation pressure. It turns out that if you just look at whether or not the IRP is abnormal in the supine position, it doesn't really correlate well with symptoms or how well the bolus transit. But if you add the upright IRP and measure the IRP when they're in the upright position, it turns out it can help reduce the amount of overdiagnosis of outflow obstruction. This is a study that was done looking at patients with abnormal supine IRP. And then you measure the study group measured the upright IRP and also did a number of assessments, including looking at whether or not there's radiographic evidence of obstruction or how severe the dysphagia symptoms are. As you can see here, in this group of patients, if they also have an abnormal upright IRP, they're more likely to have signs of obstruction on radiology or have more severe dysphagia symptoms. And an IRP of 12 at the upright position, especially if you're using the Medtronic system, has been shown to be helpful in identifying these outflow obstruction. And there might also even be other findings on the manometry that would suggest it's obstruction as well, like having what we call an increase in intrabolus pressure. So it looks like IRP is helpful, but not just with one metric. You need at least 2 metrics to help you increase the diagnostic accuracy. It turns out that how the esophageal function, how the esophageal body function is also relevant. There have been a lot of study where that's shown that if there's an abnormal EGJ outflow, if they also have an esophageal body abnormality at the same time, they're more likely to have a decrease in bolus transit in these patients. There's a few studies, including one that we did, where we basically look at people with an abnormal EGJ outflow and what their esophageal body peristalsis diagnosis is actually help predict what type of symptoms that they may have and how severe their transit symptom is. There are also other reasons why there are limitations to this IRP metric if you just look at it in isolation. One is something called an LES pseudo-relaxation. Take a look at this example where during a swallow, a very hypercontractile and spastic swallow, what happens sometimes is that the longitudinal muscle of the esophagus also contracts, and it ends up pulling the upper esophageal sphincter proximally. So it's getting pulled up. And you can see here, this is where the lower esophageal sphincter is. If you measure the IRP just at the same spot, you might get a very low IRP because you're not actually measuring the right LES anymore. But if you move it up and measure where you think the IRP actually is, where the lower esophageal sphincter actually is, then you see that it's actually still elevated. So this pseudo-relaxation can actually lead to a lot of misdiagnosis as well if you don't look at these carefully. Another limitation is the effect of using opioids. If patients are opioids when they come in for the manometry, that can cause the IRP to be high, and oftentimes that's reversible once they get off the opioids. The third thing is if there's any effect of structural lesions. So if patients have either a RAP and they have a hernia, or there are other obstructive lesions, like a physical lesion, that can also lead to what would look like an outflow obstruction with an elevated IRP, but you might actually be looking at something anatomical. And also, there are also conditions where even the IRP, when they're normal, it might still be an obstructive physiology. For example, in patients with absent contractility, some of them, the measured IRP might be in a normal range, but they might actually have a physiology that is similar to achalasia. And the next slide is basically talking a little bit more about that, the limitation of this diagnosis of absent contractility. Remember, per Chicago classification, absent contractility is when you have a normal IRP, but completely failed contractions throughout the study. But it turns out that this is a study from Dr. Gwali's group looking at patients who have this diagnosis per manometry, this absent contractility diagnosis. And when they look closer in doing further study, including barium esophagram or endoflip, it turns out a portion of them actually have signs looking like achalasia, including an abnormal timed barium esophagram or an abnormal endoflip. And it turns out that if you look at the threshold of IRP for achalasia diagnosis and absent contractility, it's lower than what you normally use that's been recommended. And pressure of 10 millimeter mercury might be more accurate in diagnosing these outflow obstruction in these absent contractility patients. So if you see patients with absent contractility, even if they have a normal IRP, you may have to consider achalasia. Maybe think about doing further study like endoflip and timed barium esophagram to make sure that you're not missing them. Another limitation is ineffective esophageal motility diagnosis. It's really uncertain when we make this diagnosis how significant this is. There have been studies that have shown that this IEM diagnosis, even per the most recent protocol of Chicago classification, may be present in about up to 10% of healthy asymptomatic individuals. So a lot of people may have this IEM pattern where they have an increase in ineffective swallows. Even though compared to the last version of Chicago classification, the current one is more accurate in diagnosing what's relevant in terms of IEM, there's still no significant difference between bolus transit between when it's diagnosed in the last version or the current version. And there have been studies that have shown that if you have more ineffective swallows, you're more likely to have more severe dysphagia. But overall, the severity of dysphagia is still low, even in patients with the IEM diagnosis. So what does this actually mean? All this data basically tell us that we're still not sure how significant the diagnosis of IEM is, even per the current version of Chicago classification. Even with hypercontractile disorder, it might be the same. These are a few studies looking at patients who are diagnosed with hypercontractile esophagus on manometry and looking at what was done to them. A lot of them, even if they don't get any treatment, they stay kind of the same. Or they can be treated with conservative management like PPI or some medications. A lot of them will still have symptom benefit even when you just treat them very conservatively. So symptoms often improve even with no treatment or just very conservative treatment, even in patients with hypercontractile esophagus. And this is another study basically randomizing patients to get a Botox or sham procedure. The main thing to show here is that it doesn't matter which one you do, the symptoms actually are about the same on follow-up. And in fact, a lot of these manometric diagnoses even change over time, even if you don't do anything. So sometimes you diagnose someone with hypercontractile esophagus, they had the sham procedure, they do the manometry again later, it became normal, even without treatment. So what does this actually mean clinically? Sometimes we're not sure, so we'll be very careful in terms of what to do with these diagnoses. So just a quick summary. I think the most important role of manometry, we've been talking about this, is really to diagnose or rule out these actionable motility disorders, specifically those of obstruction, so that we can treat this obstruction to help patients' symptoms. We know that EGJ outflow obstruction is a very heterogeneous finding with very multiple number of underlying causes. So when you see an elevated IRP, you really need to do multiple supportive testing to support this diagnosis and make sure they have true obstruction. If you see absent contractility, consider achalasia when there's signs of obstructive physiology. And really, when you get diagnoses like IEM, hypercontractile esophagus, or even spasm, without evidence of obstruction of manometry, you need to be very careful in terms of what to do with them, because we're still not completely sure what the clinical relevance of these diagnoses are. Thank you.